Welcome. It's Heart Talk Tuesday. We're going to be talking about peripheral artery disease. I may or may not have a guest tonight. If not, we'll try to reschedule him. But, we potentially could be joined by Dr. Bernard Ashby. But if not, no worries. I'll just kind of talk about some of the points that we were going to discuss. And then if he joins us, he'll jump right on and tell us about who he is, what he does, and a little bit more about peripheral artery disease, because that's his specialty. And then I have another physician who's going to come on in the next couple of weeks. He also specializes in reducing amputations and manages people with peripheral artery disease. And he's gone viral with how he's been able to save a lot of these folks. He's been able to save a lot of these folks from having their legs amputated. Greg, tap in people. Oh, indeed. All right. So I'll just get started. This weekend is Father's Day. So, before I forget, happy Father's Day. I know you all are working very, very hard trying to keep your families together, trying to keep yourself together, trying to stay sane at work so you can continue to make the money that you need to make to take care of your family. And so I don't think we give men enough props as it relates to their selflessness in terms of trying to generate wealth for others. And so I just want to say kudos to all you all who work very hard so that you can provide for your families. And sometimes that means putting yourselves on the back burner, which, I certainly commend, but just want to say that it's always good to put the mask on yourself before you put it on other people. So this is what this, month is dedicated to. It's a Men's Health Month, and just kind of reminding men, hey, your health is important. Your self-care is important, just like it is for women. And so I just want to make sure that I'm providing you all the information that you need to be happy and healthy. And before y'all comment, yes, I know I got all my grays going. My hair is gray because last week, we had a lot of sick patients. Basically going from room to room telling people that their family members are just dying. And it's always hard, but if someone's older and they've had these discussions with their own doctors and it's known, then that blow is not as tough. But when they're meeting a new face like myself in the hospital, and let's say they're young and this could have been prevented, but now I'm seeing them at the very end of, their heart failure, where they're basically dying. That really frustrates me because, you just see that the system has failed folks, and then also folks, have trouble with wanting to do better for themselves. And that may play into having to help everyone else and having challenges with compartmentalizing and coping with that. But I just, want you all to really just, at this juncture, 40s, 50s, really be mindful of your health and, making sure that on your calendar that at least once a year, once every 6 months, whatever your doctor recommends, that you're seeing a physician with that kind of frequency, with that cadence, so that they can make recommendations and look for anything that they can do to lower your risk for cardiovascular disease, because we're heavily invested now in prevention. I used to work with the American Heart Association, and that really is the guide, is to help prevent heart disease. I want to get to the point where we don't have to deal with heart disease as much. And by then I'll probably be able to retire. So it's a win-win for me. Anywho, I was going to talk about amputations, and so I'll touch on it now. And then when one of our guests who specializes in peripheral vascular disease, when they're more available, then I can have them come on. There's some interesting statistics I found that peripheral artery disease for African-American males, their lifetime risk is approximately 30%. So that's almost 1 in 3 African-American males are at risk for peripheral artery disease. So that's fairly scary. And a lot of you are probably wondering, what is peripheral artery disease? Well, peripheral artery disease it describes the vasculature that goes to your legs, but also, your carotids are also considered peripheral. So, but if you have disease, if you have plaque in your legs, you probably have plaque, you could have plaque in your carotid arteries, and you could have plaque in your coronary arteries. So peripheral vascular disease is just sort of a canary in the coal mine to say there's probably plaque all over, and that, heavy intervention and prevention, aggressive prevention is needed. And so folks who develop peripheral artery disease, a lot of times folks who have diabetes, if you smoke, and if you smoke cigarettes, the likelihood of developing peripheral artery disease is very high. And then, as I mentioned, if you have diabetes and your diabetes is, if your A1C, if you're struggling to keep it closer to 7 and it's 8, 9, 10, 11, and you start to develop diabetic complications like diabetic neuropathy, then, your risk of peripheral artery disease is also going to be elevated. So how do you know if you have peripheral artery disease? So one way is if you do have those risk factors. No, not everybody, but if you do have those risk factors, and you notice that when you're walking, you start to get cramping in your calf muscles, and that, when you sit down, it feels better. That's almost like angina of the legs, essentially. So again, only if you have risk factors. If you just came from the gym, you were doing leg day, and you're 25, you don't have peripheral artery disease. But if you are a smoker, you've been a smoker for 30 years, you have diabetes and your A1C is 9, then if you're developing these symptoms, the probability that you have peripheral artery disease is a lot higher. So your pretest probability is going to be higher than if you are, like I said, 25, you just did leg day, and now you have some cramping. That's not peripheral artery disease. So that's not something to worry about. So one thing that's important to note is that in African-American men, there's an increased risk of amputation. And so, that's not always necessary. It's certainly not always necessary for peripheral artery disease. The goal for peripheral artery disease is what we call, limb salvaging methods. So this can include stents placed by either a cardiologist who specializes in vascular surgery or vascular surgeons. And so these are ways to put in stents into the arteries that supply blood flow to your legs, just like you would get a stent in your heart. It's a very similar concept. You're opening up those tubes, which are your blood vessels, and you're providing perfusion to the muscle and, to the leg. So, and that can help with, you're going to improve those symptoms of the cramping, and you're going to be able to perfuse your feet and everything like that. So why is this a problem if you're not perfusing your legs? Well, for one, you can start to get wounds, especially if you're diabetic. If you're not perfusing your feet, some people's toes will get necrotic. Some people's toes can kind of start to fall off. My mom's an infectious disease specialist, and when I shadowed her, she was picking out bones out of people's feet, and that let me know I'm not doing that. But I was more like, I gotta do something else. But God bless her and people like her who take care of people and take care of their feet. So anyway, so those are signs of, poor perfusion. And sometimes, my mom will tell me that folks would be walking around, they come to clinic, they're talking, yada, 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 how you doing, blah, 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 blah. And then, she takes off their shoes and their socks, and they've got a nail in their foot. And they don't even know they have a nail in their foot, which is wild. But if you have poorly controlled diabetes, smoker, you have peripheral neuropathy, you're not going to feel it. So, this person had probably some terrible infection, probably tetanus, and didn't know because they didn't really take off their shoes, didn't really take off their socks and things like that. So that's scary. That's certainly the extremes. But, it's just a reminder to say, if you have these risk factors, it's always good to check your feet every single day. Check the bottom of your feet, the top. If you're a caregiver and you're taking care of a loved one or a family member who has, peripheral artery disease, it's good to just kind of take off their shoes and socks and check their feet. If you get infections, do not put whatever people put on it. Don't let the cat lick it. don't let the cat lick your feet. Don't try to put in Epsom salt or, just let your physician know, and then they'll hook you up with some wound care. And that will be a better way to manage your feet, manage that infection. All right, so moving on. So if there's challenges with perfusing the leg, after people have tried, then kind of amputation will be the last step. But really, again, the goal is to detect it early, start medication, see if the medications can help. Aspirin, cilostazol is another medication, and also statin medication, trying to keep that LDL down. We always talk about that, but you're going to want to keep that LDL less than 70 to really help prevent buildup of more plaque in the legs. So if these things happen and the disease still progresses, then like I said, it's a last ditch effort for amputation. But unfortunately, within our African American male brother and sisters, brothers, excuse me, not sisters, but with our African male brothers, the risk of amputation is quite high, unfortunately. I'm sure there's a multitude of factors. One, sometimes folks don't want to see the doctor unless they absolutely have to. Just because probably, they're busy, they're providing for their family. They know that when I see men in the hospital, they're really sad about being there is because, I left my wife there, or I left my family there, or my pets, or something that they've left that they feel, obliged to need to take care of. But, again, you got to make sure that you're getting your visits in and making sure that you're getting that assessment for peripheral artery disease. So other things, I'm going to be honest, in medical training, a lot of the bodies that we're learning on are not brown bodies, right? So if we don't see, if we're not seeing a lot of brown bodies in our textbooks, we have Netter's, which is an anatomy textbook. Well, if we're not seeing a lot of brown bodies in Netter's or Harrison's, which was the major internal medicine book, then it's going to be harder for us to be able to identify peripheral artery disease in someone who has darker skin. So, on the one hand, it's making sure folks get their checkups, but then on the other hand, it's from our perspective, and as physicians, we need to do better about changing the illustration so that we know what brown and black bodies look like and what pathology looks like in these folks, because we are all American, and there's no reason why we shouldn't be able to identify disease based on skin color. I think that's really ignorant. And so, I think those two things are challenging. Also, if you're in the clinic, you're kind of busy, you got to go from here to here, you may not stop and sit and take your shoes and socks off. But I will say, if you're struggling with diabetes, no shame. Or if you're struggling with smoking, no shame in that either. But if you are, then do your best to take your shoes and your socks off when you're in the doctor's office, just to kind of as a reminder for them, especially if it's your primary care and they're trying to just check boxes. Okay, did you get this cancer screening? Did you get this and get that? Okay. You're like, you have your feet out there so they can see it. And so when they're going to do an exam, they're going to have to at least touch the feet and see. Feet are really important. When I have patients who are in, cardiogenic shock, more than likely you're going to be very ill, very sick. You'll be in the hospital. But I always take their socks and shoes off and feel their feet. And my feet are typically cold, but their feet will probably be very, very cold. And that's something that, clinically can be helpful. Also, if you have signs of heart failure, sometimes the swelling may just be kind of in the ankle. It may not be as obvious if your legs are really big. And so if you take your shoes off and then I'm putting my finger in your ankle and it's sinking in your ankle, that's a little bit more of a pitting edema. So that on top of if you're not able to lie flat at night, or you wake up in the middle of the night short of breath, or you find yourself needing to sleep in a recliner chair, that's a sign of heart failure. But again, this is typically in people who have risk factors, but we are seeing disease, advanced disease, peripheral artery disease, heart failure in just younger people, especially within our African-American community. I'm seeing a lot of folks who, diseases that you may see what you're used to seeing in someone's 70s, we're seeing now in folks' 40s and 50s. And not just African Americans, really everybody. But as we know, there are challenges as it relates to healthcare within our African American community. And so that makes it a challenge for sure. But if any of y'all have questions, somebody asked about, is Zepbound good? What about Ozempic? So I've been heavily reviewing the data for Zepbound. It's tough, and I'm not 100% sure if they've done a head-to-head Ozempic versus Zepbound. So I'll have to get back to you on that to see if they've actually done a comparison to see which medication helps reduce your cardiovascular disease risk more, whether it's Zepbound or Ozempic. But just a lot more data, at least that I've seen anecdotally, has come from Zepbound in terms of reducing cardiovascular disease risk factors, including and reducing cardiovascular disease as well. And you also get optimal weight loss. Because, the pandemic that we're seeing, I would call it a pandemic of heart disease, heart failure, a lot of it's obesity. And again, no shame. I think the foods that we eat, that we put in our body in this country, it's not food. It's not food. I don't know what it is. But if you go to another country and you're eating fresh food, you see the difference of like, okay, this is what food is. I'm not really sure what we're eating. So Grace said, can you speak to the connection between heart disease and belly fat? Yes. So visceral fat. So a lot of us are different body types. Some people may have, a little bit more junk in the trunk. That's okay. But if you have more of the, I guess you would say apple shape, or if you have more belly fat, that is an indicator that you have a higher risk for cardiovascular disease. And they talk about visceral fat. So that's an indication that you have fat around your organs, which is not good. When I was a medical student, I was able to see autopsies, which was kind of cool. It's like Law and Order. It's like, what do you got? It's terrible, it's sick, but you have to be interested in this kind of stuff, obviously. So yeah, I would see people who they take the heart out and there was fat all over the heart. So, the heart has a conduction system. If fat creeps into the muscle, then that impacts the conduction system of the heart. And that can put you at, increased risk if you have heart failure for deadly heart arrhythmias. So, having fat everywhere is not good. But if you have that sort of visceral fat, you've seen folks where they're kind of thin, but then they've got a lot of that kind of belly visceral fat. That is higher risk, and that can be challenging. The other thing is interesting. I know it's off topic from peripheral artery disease, but, Greg, you reminded me of this on this particular topic, is that some people are so obese that they're actually malnourished. Typically I see this in folks that are like over 70 and they're still 250, 300 pounds. Those people tend to be malnourished. They may not be eating a lot, but what they do eat is just not providing any kind of nourishment. It's not helping. It's not pulling its weight as it relates to, your body's metabolism and how to make your body more effective and more efficient. So they will, a lot of times I tell them you need to drink protein boosts. So you need to get your protein up, because if you get heart failure and your protein is low, all that fluid just comes on out, and it's really hard to treat because I need it to be able to get in your blood vessels and for you to pee it out. But if your protein is low, then fluid leaves the blood vessel. But if your protein's high, it can come to the blood vessel. I can get all that fluid in that vessel. It's going to go to your kidneys and you're going to pee it all out. But with folks who are malnourished, we're just kind of stuck with that, because you can give them albumin, but it's not really a long-term solution. So, again, if you see somebody who's obese and you're thinking, you can be malnourished and be obese. So it's not good to be too big and it's not good to be too skinny. If you're a little bit overweight, that's fine as long as your numbers look good. Your LDL is less than 100. Your A1C, you don't have diabetes. That A1C is less than 5.7. You don't have sleep apnea. So, ask whoever you're sleeping with. I'm not going to ask, but whoever it is, just say, do I snore at night? Am I snoring loudly? Or do I stop breathing? Sleep apnea is very prevalent in the community, in the communities that I've practiced in the South, in North Carolina and Kentucky. And so if that's the case, if you stop breathing at night, you absolutely need a sleep study. They do have home sleep studies, but I would recommend going there. I know it's weird having people watch you sleep, but I just think the data you're going to get is just more comprehensive. You only have to do it one time. I had a friend who did it. He did it, got his CPAP, and he's fine. But the problem with sleep apnea is you can develop pulmonary hypertension. If the pressure in your lungs get too high, that can cause RV failure. If the right side of your heart fails, that is not good because there are not a lot of solutions for RV failure. LV failure, we have more options, but if the right side of your heart goes, it's either you need some kind of assist device or you need a heart transplant, and it can be challenging depending on your candidacy and everything. So it's really, really important to recognize sleep apnea. So we talked about A1C, we talked about LDL. These are all things that are called the Life's Essential 8, and it's an American Heart Association recommendation, and it just kind of touches on all these things: diet, being active. Obviously you want to eat clean, high protein, more vegetables. Does amlodipine cause you to lose weight or muscle? No, Sean, is that you, Sean? No, it doesn't. It does not cause you to lose any muscle. Amlodipine can cause some swelling in your legs, but like your ankles typically. But that's about it. That doesn't mean you have heart failure. It's just it's a side effect of amlodipine, but it's not going to cause any loss to your muscle or anything like that. So Jared says, I have sleep apnea and use a BiPAP machine. That's awesome. There's no shame in that because you're protecting your heart. Another thing about sleep apnea. Sleep apnea is associated with the arrhythmia that I cannot stand, and that is atrial fibrillation. If I never see AFib again, I will be happy. AFib, the lifetime risk is approximately 25%. Very prevalent heart rhythm disorder, extremely prevalent. And so I was telling you all that we're seeing younger people with these comorbidities, right? Younger people with heart failure, poorly controlled diabetes, etc. And so that's also going to increase your risk for atrial fibrillation. And once you get AFib, it's like a roach. If you see it, and one of my attendings used to say that. He said it's just like a roach. He's African. It's just like a roach. He do that. And so once it shows up, it can show up again, and it can show up again. He said, I had AFib but no longer have it. Yeah, the tough thing, Jared, though, is it's tough because AFib can creep back in. This is when it's awesome that you're wearing the BiPAP, and that will help keep it at bay for sure, which is phenomenal. You are doing all the things. So I want everyone to use Jared as an example of how to manage your health. But if you had a surgery or going to the hospital for let's say you have influenza, AFib can come back. And so it's really important to know what your stroke risk is. It's something called the CHADS-2-VASc. So if you develop atrial fibrillation, you go on the computer and type just CHADS 2, the number 2, VASC, VASC, CHADS-2-VASc. And if you're a male and the score is 2 or greater, you're at high risk for stroke. Your yearly risk is higher. And if you're a female, 3 or greater. So when they use those particular scores, they say the risk of reducing stroke is greater than the benefits of reducing stroke is greater than the risk of, say, the bleeding side effects of the particular agent. So kind of at this cusp, we recommend taking a blood thinner because you're going to get more benefit than the risk of the blood thinner for the most part. Now, there's some people who have high risk for bleeding, and those particular people are a different category. And in those times, we can recommend something called a Watchman device, which is something they kind of shimmy up the vessel, and it sits in something called your left atrial appendage, which is this pocket that hangs outside of your left atrium. So with this Watchman device, it sits there, and whatever clot forms in that little pocket is not going anywhere. It's not going to your brain. The risk of stroke is low with the Watchman, but I wouldn't necessarily say, okay, well, that means that I just want to go for a Watchman device, because when they looked at a new trial, it was called Champion AF, which was kind of funny, AF. But anyway, what they found was still the reduction in ischemic stroke was lower with a blood thinner than the Watchman device. But they do these composite outcomes, and I'm not going to get into it, but they say, oh, this is better than this, but you have to look at everything they included. And that could include bleeding. So, of course, the Watchman device, you're going to have less bleeding than a blood thinner. But if you look at the fine print, there was an increased risk of ischemic stroke with the Watchman device compared to blood thinners. So if you do meet criteria for blood thinners, it's still better at this juncture to be on a blood thinner until they get better at, the Watchman device technology. Or they have something called left atrial appendage excision, which can be done if you have a bypass surgery, or I think they're looking, and you'd have to talk to an electrophysiologist about new advances about trying to clip the left atrial appendage more, as a more minimally invasive approach. I would say, I think that's still a great idea. And then, but we'd have to think about, how long do we want to keep people on blood thinning agents and whatnot. But we need something that's going to be just as effective at reducing ischemic strokes as a blood thinner is, before I would say, choose that thing over a blood thinner. So I hope that makes sense. So we covered a lot. We talked about peripheral artery disease. We talked about risk factors for that. We talked about the importance of limb salvaging. We talked about the increased risk of amputation. Another point I want to make is that, African-American males, they find tend to show up later in the disease process, where they can have something called critical limb ischemia. And at that point, it can be very challenging to salvage the leg. So again, if you have those risk factors, diabetes, smoking, and you're starting to feel those cramps in your leg, call your primary care and book an appointment and say, this is what I'm concerned about. And they'll do something called an ankle brachial index, and they'll check to see if there's issues with perfusion. We also talked about Life's Essential 8 from the AHA. AHA stands on business. So, I've worked with them. I was a blogger for them when I was a fellow. And they let me write whatever I wanted to write. And I said, hey, cardiology fellowship is a little bit too racist. I said it. And I said what I said, but I didn't say it in that way. I was more diplomatic. And I just said, if you want to try to create an environment, a healthy environment for trainees, this is one consideration, especially if you have African-American trainees, because we're quite rare. There's, in terms of African-American cardiologists, I'm not sure what the percentages are, but academic physicians is quite low. I think it's, less than 5% academic African-American physicians or something like that in the country. Cardiologists is probably, for African-American male cardiologists, low. African-American female cardiologists like myself, I probably know most of them. I may know most of them, I don't know. I think there's one in Canada as well. So probably, I would gauge maybe around 50. I tried to pull the data for all the women that met that criteria. It's maybe around 50. But think about that, the percentage of cardiologists that there are, and then think about, how many of us are there. So not many. So I just felt the need to kind of speak up and just say, hey, I know you're not exposed to us as much, but we're all on the same team. And sometimes it just helps if you don't know someone to try to give them the benefit of the doubt. And then just kind of go from there and let the work and the deliverables speak for themselves. And also give them the grace that you would give anyone else who's training. Especially myself, who I had a baby. And I was doing 30-hour call and not a lot of support. So I wrote this blog to say, hey, this is not good. It's not great. But what I know is that I'm needed. I know I'm needed. So I need to survive this fellowship. So if we could try to play nice for a couple of years, I'll do my work but it's not that I'm contentious. It's just sometimes if folks are not accustomed to people who look different, then they may have the assumption that this person doesn't know a lot. Or as us, African Americans, as we go through training, they all assume that we're there because of a DEI initiative. You always hear that. You're only here because you got a leg up. No. For one, you have to pass your boards. You have to pass your medical tests. You have to go through your residency. You have to have decent outcomes. You have to show up because, the margin of error for us is like this. I was explaining this to the nurses. I said, the margin of error for me is that. The margin of error of Dr. So-and-so, a male, is that, right? So I'm this. So if you see that, that means that we've dealt with a particularly challenging margin of error, despite all the other life challenges that come with that. So all that being said, it was a long-winded conversation about that. Obviously, that's something that I'm passionate about. But that, the American Heart Association let me say what I said. So, if they let me stand on business, I believe in them. They believed in supporting me. And so I would direct all my patients to the American Heart Association website, and they'll talk about Life's Essential 8. It's like a circle, and it has like the different features of it, like the glucose and your weight and all this kind of stuff. And then they'll also give you like actual practical meals. Because I'm in the South. I grew up in the Midwest, so our food is not really bad. But in the South, folks like food that is seasoned, apparently. So that can be a challenge as you're trying to manage your diet. But you can season your food, just make sure that your proportions are smaller. So don't add salt. Try any kind of alternative, no salt. And try to stay away from anything fried. Try to do lean meats. Try to do fish, vegetables, but pick because this can get complicated. So pick 4 meals that you like to eat and do the best you can with making it as healthy as you can, but still taste good. And then do your best to stick to that plan. And then Friday, Saturday, whatever, you're going to slip and have a burger, okay. But just don't make a habit of bad habits, if that makes sense. And that's what I try to do. But as I've been traveling, more busy, now working as a mom, and when my daughter's with me, I'm a single mom, and then I'm flying once a week, either to work or back home. So when I started flying and doing a lot more work, life got pretty much more stressful and challenging and more difficult for me to schedule my workouts and things like that. So I still work out, but I just kind of slipped a bit. LDL was creeping up, and then I mentioned in another video about my lipoprotein A was very high. So I decided, hey, I needed to help try to take the edge off as I continue to work out and do the best that I can. And so that's why I decided on the GLP-1. And I did decide on the tirzepatide, just because there is just more data out there for it. And it just takes the edge off. It just gives me a little bit more security, a little bit more less anxiety, about this LPA number. So I can keep it moving, so I can keep it pushing and do what I need to do. I don't want to sit here and think about lab numbers. I like to take action. And so, the GLP-1 has been something that's been great for me. I don't get any money from Eli Lilly. I've told folks that I have invested in the stock. The stock's doing pretty good right now. And so I think it's worthwhile, just especially considering they have cardiac medications as well as chemo. So someone says, hi, I have a UTI, please can I avoid more damage? So if you have a UTI, you can go to urgent care, and they can test you to see, more than likely if you're a female, the sensitivity and specificity of a female just saying they have a UTI, the probability is very high. So what you want to do is either call your OBGYN if you have an OBGYN that you see, or your primary care. But if they're not available, or if it's after hours, then I would recommend going to an urgent care and getting tested, and then they can prescribe you antibiotics. Because if you let a UTI sit for too long, you can get something called pyelonephritis, and you can get septic. So that can be that can be quite dangerous. So those are the things that you can do for UTI. But otherwise, that's about it. I will circle back with my colleague and see when a better time might be. Otherwise, I have another physician who's, like I said, gone viral because he's been able to reduce the amputation rates where he is. And so he's very enthusiastic, and so I'll give him a call I'll schedule him to be on Heart Talk Tuesdays as well. And I think that'll be an awesome discussion, and hopefully that's something we can do this month in June, since it's Men's Health Month. I want to make sure that I'm lifting up the men physicians and hearing the males' voices, because I think that's the best way to help try to improve our health, is so that they can hear it from the source or hear it from somebody that they can relate to, and someone maybe that can share their experiences, and just someone that you can feel that they can ask questions to, and no questions are, all questions are welcome, because, we don't expect you to know medicine. You didn't go to medical school, so it's okay to ask anything. When I do anything, even the bank, I'm like, what am I supposed to do? Do you still write a check, or how does that work? When I go anywhere else, I don't know anything. I go to my lawyer's office. I'm like, what does that mean? Where do I have to sign? And I don't have the bandwidth to sit here and talk to you. Just everything else, when I go to the grocery store, everything else can be frustrating for me to try to figure out. So I get it. I totally get it. So again, if you're finding challenges with medicine or with understanding things, you can always come in these forums. We can always talk about it. Like I said, there's no question that it's too dumb. And, unfortunately, in different pockets, people will say, well, the health literacy is just quite low in people. And I don't think they just know enough, or they just don't understand they need to come to the doctor. People know they need to go to the doctor. People get that. But they also know that if they show up to the doctor and someone has that mindset, why would they want to go? Why? If they already think that you think that they don't know enough. But I've had experiences where I've had to do a lot of things myself, and I get it. And the people I leaned on were not physicians when I really needed help. So I can understand, if you're busy and you're just trying to get the information, it's also very nerve-wracking. So anyways, hopefully I can be that, physician for y'all. So I am going to close out. If you have any requests for the remainder of the month that you'd like me to touch on, please feel free to leave it. I'll download this. It'll be on YouTube, but then I'll have short segments. And then within each, particular short segment, if you have questions, just let me know. I'm happy to answer, except for I'm going to be a little bit tied up this week. I'll be going to Chicago, but after that, I'll be available. All right. Well, y'all take care. Have a wonderful night. I hope you learned something, and see y'all next time.